Hi, this is Brian Kim. I'm going to share with you this case of a patient who came to see me. She had a really bad corneal ulcer, took a long time to heal, severe inflammation, intraocular inflammation as well. And so you're going to see here a couple of things: a really dense cataract, a dense central corneal scar, iridocorneal adhesion. It actually required removal of Descemet's because of this dense adhesion, so I had to actually lyse it off. This is a totally secluded pupil, had to get under it, peel off a membrane, and of course there's a small pupil as a result of that as well. And so this is really one of the most extreme cataract surgeries I've done. And now this patient refused to have a corneal transplant. She refused to even have cataract surgery. She's one of those that really was very scared of everything. And so I had to really convince her because, she couldn't see. And I said, look, at least let's try to do cataract surgery. And if this can give you some level of vision, then we'll leave you alone. Her other eye was relatively okay. And so she went ahead to do this. Of course, a corneal transplant would be a strong consideration. But considering her fear and her limitations for follow-up and her medical issues, we went ahead and did this cataract surgery. Again, super extreme cataract surgery challenge, and you'll see how I navigate through and make the decisions to do this cataract surgery in the way I do it. So you can see the eye here. There's a dense corneal scar. It's central as well as inferior. You can see all the corneal vascularization. This is, again, from a healed corneal ulcer. I'm using the corneal marker, which will help me to center incisor rectus. I do this for every single case, and I don't want to deviate from my standard technique. Making sure my incisions are parallel to iris plane, which will create a nice corneal shelf and allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to fill the anterior chamber. And then I'm going to go ahead and make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, turn the eye towards me, and then I enter. Now, so far, all you see is just a dense corneal scar as well as this secluded pupil. I'm going to use microforceps as well as my sharp tip Halti Percar forceps. And with a two-handed technique, I'm going to peel off this pupillary membrane. And the reason why a two-handed technique is so helpful is you can have control of the pupillary edge with the left hand as I'm peeling that membrane off with my right hand. What you don't want to do is just yank on the pupil, and you're causing traction on the iris root. And in some extreme cases, if there's severe fibrosis, you can actually cause disinsertion of the iris root. And so this is a much more controlled way of peeling off a pupillary membrane in this situation. Now, this is what I'm noticing here. This is really where I kind of got wigged out. There's actually a Descemet's adhesion to this pupillary membrane right there, right over that dense corneal scar. So I had to kind of sweep that defect back. And now I'm like, okay, what the heck was that? I've never seen that before. And so I have a decision to make. I decided to go ahead and just amputate that adhesion right where it was coming from. And I had to do that because as I'm doing the cataract surgery with all that irrigation fluid, and I'm going to be using vacuum, you can see that piece of that Descemet's is coming out right there. I had to do that because I can't allow my vacuum to grab Descemet's while I'm doing the cataract surgery. I got to focus on the cataract surgery, and that Descemet's would get in the way, and it might actually make the tear worse. So I had to amputate it. So now I'm putting trypan blue in. Remember, you can put trypan blue in the eye even though there's no bubble and even though there's a lot of viscoelastic. You just place it right over the capsule, push very gently, and then just mechanically just paint roll over the anterior capsule with the trypan blue. So now I'm pushing with dispersive viscoelastic. You can see there's a really nice painting of the anterior capsule surface with this technique. And so these are the sharp tip Halti Percars. Once again, these are a great set of forceps to be able to puncture the capsule as you see here. Again, it works as a cystotome as well as forceps. So I'm able to puncture and then I'm going to start to go around very carefully here. Thankfully, this is not an intumescent lens. That would be a next level extreme cataract surgery if that was the case. This is just a 3+ dense lens. Again, able to get around that Descemet's tear there by amputating that free tear. Can't have that tear floating around while I'm doing the cataract surgery. And, we'll have to deal with that later. If she has a decompensated cornea, she'll have to have, additional corneal surgery. But I got to focus on the cataract. I can't focus on that right now. And so that's the thing. You got all this stuff in your mind. You're just worried. And now here you can see I did my rhexis, but I can't see under that scar. It makes me a little nervous. So I'm just going to go around on the other side and make a snip with my scissors. And then I'm going around on the other side to finish off the rhexis. So never put yourself in trouble when you're already dealing with a really stressful situation. Just go ahead and make your life easy. And as you could tell on the superior half of the field, I have a fairly good view. Of course, there's still scar there, but it's just a fainter scar compared to the inferior half where I just don't have good visibility. And so instead of going down a dark alley in the middle of the night, why put yourself in a potential dangerous situation? Go ahead and snip on the other side, take a detour, and go ahead and finish off the rhexis as I did. And this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, decompress on the left side, sweeping the anterior capsule on the left side as well, and then going on the right side, hooking the peripheral lens. You can see the lens is spinning quite nicely, which is really a great thing, especially in this situation. It's really nice to have a mobile lens when you're dealing with a really extreme case with a dense scar, Descemet's defect, and the pupillary membrane adhesions and so forth. And so go ahead and adjusting my sleeve here, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. I'm going to start removing the surface epinuc material, and because double chop and cross chop is really a tactile maneuver, I'm able to place the chopper under the rhexis edge contra-incisionally, turning the phaco tip vertically sub-incisionally, fracturing the lens completely in half. That's double chop, placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing the lens between the instruments, and that is the cross chop, bisecting the right heminucleus. Using some vacuum to lift that first quadrant up, and be able to emulsify it pretty easy, placing the chopper around that piece again. And this is what you're going to notice I'm doing. I'm turning the lens, but I'm trying to make sure I fracture the lens where I can see it. I'm not fracturing it under that scar. You see that? I'm actually making sure I can visualize what I'm doing. And it's almost kind of like analogous to, in this case, working through a keyhole, because I'm limited by the pupil, right? But I'm also limited by that inferior corneal scar. And so I'm really working within that superior half of the pupil and superior aspect of that cornea. And I'm just going to work in that relatively clear zone there, even though there is a scar there, just not as dense. And I'm performing cross-chop maneuvers, fracturing the lens with the instruments. I have exquisite control because I know that I'm hooking the peripheral lens confidently. I'm not going after it with vacuum. I'm not using high vacuum to pull lens pieces up out of the bag, which in this case would be very dangerous. Because once you break bag in this situation, you have so many elements against you already. Small pupil, dense scar, Descemet's defect, and things can really spiral out of hand. So I've already gotten rid of that first heminucleus. I turned that second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, bringing the chopper toward the phaco tip and fracturing the lens completely in half. Going after the third quadrant on the left side. Again, why? Because it's clearer over there. And I was able to crush that fragment using some vacuum to lift that piece up, getting the chopper around the lens, hooking the peripheral lens and crushing it. When I'm fracturing the lens, and when you see the video, you'll see there's this sudden loss of resistance. It's almost like a snap. And that sudden loss of resistance when I'm fracturing the lens and I'm bringing the instruments together and I'm compressing the lens fibers, that is indication of how dense this cataract is. And that's kind of how you get a really good feel for how dense it is. So again, this is my last quadrant, lifting it up with some vacuum, sandwiching the lens pieces between the instruments, and then emulsifying the lens pieces. Again, this is really a 3+ dense lens, pretty dense, not a 4+, not a 2+. You see the CDE, and I can't help it but use some CDE in this situation. I need my fluid and my phaco to my advantage when I'm dealing with this really challenging situation. Poor view, small pupil, Descemet's defect. I just don't want anything to get worse. I can't phaco up near the cornea. I might grab Descemet's. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the IA handpiece. And again, it's important here not to direct the IA towards the cornea, because what if I grab that Descemet's and then start causing a descemetorrhexis? You don't need that. You don't want that. And I promise you, there's a defect in Descemet's right over where that scar is because of that dense adhesion between the iris as well as the cornea. I start subincisionally with cortex removal, peeling from anterior to posterior. I'm going around circumferentially very carefully and using foot pedal control to very carefully grab cortex and trying not to grab iris when I'm doing this. I switch to polish mode, polishing underneath the rhexis edge, polishing the posterior capsule as well as in the subincisional area. And again, these are all things you're thinking about when you're doing cataract surgery. You're wanting to make sure you don't grab Descemet's while you're doing this. You want to make sure you protect the posterior capsule. You want to make sure you don't grab the iris. You want to be able to disassemble the lens carefully and confidently without hooking the bag, just hooking the lens instead. Go ahead and inject a single piece acrylic lens into the capsular bag here. And even if the view is not great, I'm able to, again, utilize the cues that I know when I'm doing cataract surgery to be able to execute the surgery confidently. There's no way you can do this surgery if you can't see, but more importantly, you can't do this surgery if you're not confident, right? And, some of the maneuvers that I do with double chop and cross chop, I trust my maneuvers. I trust that I know where my hands are. It's no different from when you're shifting gears on a car with manual, or you're putting your belt on or whatever for your pants. You don't necessarily have to see what you're doing. You could do those maneuvers without looking at your hands. And so that's a similar kind of concept. You have to have a good understanding of where your instruments are. You have to understand that I'm able to push down on the epinuclear material and slide the chopper under the rhexis edge, even though the visibility is not great. And because I understand the mechanics of what I'm doing, I stay out of trouble. I'm able to hook the peripheral lens instead of hooking the bag when I do that. You can see here I'm using the Maltzman to retract the pupillary edge to make sure that both haptics are in the bag. Of course, in this kind of situation, it would be terrible that you've gotten this far and you've done everything great, the best as you can, and then you leave one of the haptics in the sulcus. It's just not good technique. And in my opinion, you should never, ever have a haptic in the sulcus. You have to check. If the pupil's not great, just use something to retract the pupillary edge, and you should be able to visualize that the haptics are both in the bag. This is another reason why I like to go underneath the lens when I remove viscoelastic. Some people don't do that, and then what happens, there's sudden removal and the whole bolus of viscoelastic underneath the lens that's in the bag still trapped jumps out as you're using vacuum. And when that happens, it can cause the haptic to pop out, especially these single piece acrylic lenses. And so the easy way to get around that is to just tilt the lens and get under it. Some people do this maneuver where they push down on the optic as they do that. But okay, if you push down on the optic and you're trying to make sure that the haptics come out, well, that means you might be tamponading and incarcerating the viscoelastic as well. And so you don't need viscoelastic retained in the bag when you're doing cataract surgery. Just tilt the lens and get it out. No big deal. And then after you do that, use a Maltzman or some type of instrument to make sure both haptics are in the bag. Again, you saw that I had to amputate Descemet's. So starting from the beginning again, you saw there's a dense corneal scar. I had to peel off the pupillary membrane. I have a smallish pupil, dense cataract, big old scar. I also had a huge iridocorneal adhesion, and I had to peel off Descemet's and endothelium right over that corneal scar. Actually had to amputate it off. And during the surgery, I'm mindful that I don't want to grab that Descemet's tear and propagate it and make it worse. And so everything is very complicated when you're doing these cataract surgeries. But because I trust my technique, I trust my maneuvers, I trust my hands, this can be a very routine surgery, especially with double chop and cross chop, leveraging mechanical fracturing forces, implementing crushing techniques to crush the lens mechanically, not going after lenses outside of the central safe zone with high vacuum, which is very, very dangerous. Rather, hooking the peripheral lens with the chopper at the equatorial side, and then sandwiching the lens on both sides of the lens, crushing it, effectively fracturing it, and then very carefully breaking it up into smaller pieces, as we all do, and then removing the lens pieces with high vacuum and pulses of ultrasonic energy. This patient she actually did quite well. Her vision, I believe, best corrected is around 20/50. She's very, very happy with her vision. She doesn't want to have a corneal transplant. Again, she's kind of a nervous person, and so we left her alone. The other eye sees really well. And so this is how you're able to deal with an extreme cataract situation where it comes with careful planning, learning to pivot, and making quick decisions in the middle of surgery when you didn't expect it, just like when I saw that Descemet's adhesion to the iris. I had to make a decision on how I'm going to deal with that. You can't just abort the case once you're started. And then utilizing your techniques. And you have to have high quality, confident maneuvers and techniques. And that's why I rely on double chop and cross chop. I know, if you try to sculpt and you're pushing down on the zonules and you can't see how deep you're going because you're not going to be able to see a red reflex with that case because of the dense scar. You try to lollipop the lens, you're using high vacuum. Just using high vacuum to lollipop the lens, in my opinion, works fine, but you can run into limitations when you're used to trying to bury the phaco-tip into the lens piece to chop. You saw how I do that. I don't lollipop and bury the pieces with the phaco-tip to hold it. Because why? You have to have high vacuum and you have to have a big enough piece to hold that lens. And what if you bury too far and you go too far? Well, then you'll have sudden chamber surge and you could actually grab the posterior capsule if you bury too far. Instead, you don't have to utilize vacuum and ultrasonic energy to hold the lens. Just position the instruments around the lens and then crush it. That's all you have to do. Just using common mechanics, it's just basic physics. You place the instruments on either side of the lens, and as long as they're equal and opposing, you bring them together and you crush the lens. Simple as that. Very controlled, no use of high vacuum or ultrasonic energy, which can be dangerous. I'm able to have exquisite control, fracturing the lens as you've seen, and then this patient did extremely well. And in my opinion, this is really one of the best ways to disassemble the lens. And again, luckily, I was able to implement those techniques in this very, very, very challenging cataract situation. So I hope this was helpful to you, and I thank you for your attention.